أسمعكم لكن نبتدي النهارده بالسلام الوطني.
طبعا سعدنا تواجد حضراتكم في الاجتماع الندوة الشهرية بتاعتنا. طبعا دكتور جورج هو صاحب الدعوة وصاحب البيت اللي شرفنا بوجوده ونستفيد منه دايما. أنا سمير أبو المجد النايب الجونيور بتاع الدكتورة سعاد، وهي تشايلد سايكاتريست وأنا ادكشن ميديسن، ولكن هنستفيد من الدكتور جورج النهارده. يسعدني تواجده معانا. طبعا كلكم عارفين بروفيسور جورج تاودرز، بروفيسور ليازون سايكاتري اند ديمنشن اسم ميديكال سكول ان اسم يونيفرسيتي. طبعا هو البروفيسور الزائد عندنا adjunct بروفيسور سايكاتري in Cairo University. هو الانفنتور of the project to rate the rapid assessment interface discharge in UK، وده بيطبق في اليو كي اعتقد في كل الاميننت ميديكال سكول لليو كي ان شاء الله في مصر. هو الكوردينيتور MOU between Cairo University and Aston University. شرفنا تواجده معانا. المحاضرة لا تزيد عن 5
كده
اتفضل.
I'm really honored to be here. ده شرف كبير ليا. أشكركم جدا على الدعوة الحلوة. مقابلة الدكتور سعاد، الدكتور إسحاق، الدكتور عبد الرحمن، الدكتور سمير، كلكم أساتذتنا وأنا تعلمت منكم كتير. وأكثر حاجة بتعلمها منكم الانثوزيازم والكوميتمنت. هقول لكم على حاجة غريبة، حاجتين بسرعة. أنا دلوقتي بروفيسور في أستون وبروفيسور زائر هنا. أنا كنت بروفيسور في وورك ميديكال سكول في تشستر. I had few professorial chairs, but the chair that really touched my heart when I got the title here with Cairo. That is my biggest honor. That is. واحنا بنقول السلام الوطني. أنا بقالي 25 سنة مش عايش في مصر، بس واحنا بنقول السلام الوطني I had all the emotions and I really remembered إن مصر مش وطن احنا بنعيش فيه، لكن الوطن بيعيش فينا. مصر بتاعنا كلنا. هنتكلم على liaison psychiatry، ومش هقول لكم liaison يعني ايه اصل الكلمه، خليكم انتوا تدوروا عليها. الكلمه اصلا جت من فين من زمان. لو دورت على اصلها you will not find it. Not a very nice word. But anyway, liaison psychiatry is the bridge between psychiatry and all the medical specialties, and I'm going to show you this now. I just want to see people in the room. Who is from psychiatry? Who is from geriatric medicine? Very good. Who is from medicine? Very good. Okay. Surgery? Excellent. Gynecology, obstetrics, orthopedics, cardiology. I'll show respiratory medicine, renal medicine. I'll show you what we can do, because liaison psychiatry is really, really brilliant. Right. I was talking with Dr. Maha earlier on, and the population is growing older. Even in Egypt here, people are living longer. I know the first child psychiatrist and master of Bani Khalifa and then children here, but the old age is growing and the population is growing. And to be honest, I think the future is for old age, because we'll have a big population, and this big population don't have people who are trained to deal with their problems. And it needs a lot of skills and a lot of art. So in the UK, the average lifespan for a woman is 83, and man 79. But what I want to share with you very quickly, a baby born in the UK in 2000, a baby born in the UK and lived in the UK has a 50-50 chance to live to the year to be 100. When they did the NHS in the UK, they didn't expect the people to live that long. Now, people born, baby born in 2011 has more chances to live in 100 more than people when the NHS was there. So people are growing older. But if you look, and you're helping me with the Australian, just think of the numbers in your head. In the UK, we have every year about 8 million admissions. 16 million admissions every year. 8 million of them are with older people. Now, where are these older people in the UK hospitals? In the Department of Geriatric Medicine? No. Everywhere. In orthopedics, in cardiology, in endocrinology, in gynecology, and every part. And this is what I want to think, that psychiatry should spread everywhere. If you think about them, 70% of people referred to old age to liaison psychiatry never had any psychiatric intervention before. The first time they were picked up, that's when they were coming to us. Osama told me this before. How big are Australia? How many patients you have? Inpatients. خمس آلاف. Just to keep the 5,000 number in your head, 27% will have dementia. 50% will have cognitive impairment. 25% have delirium. And 25% will have depression. Can you imagine the numbers? Who is looking after them? That should be you. Right. I'll skip this because I want to show you something else. What happened with the health of older people? You find about 25% of men and women reported they had bad health above the age of 65. Even with Dr. Samira Bulmagdi with us, alcohol problems in the UK is more in older people after retirement, and there are new people coming in. So in the hospital, because we don't think about older people, we used a screening tool for alcohol called FAST. This is FAST is for anybody. And if you do the FAST screening tool, 1% of older people coming to the hospital will have addiction problem. But if you don't use the FAST screening tool, and you use the MAST-G screening tool, which is specific for older people, the 1% becomes 18%. So if we don't focus on older people, something specific for them, we'll miss a lot of things. Again, back to the Australian. Obviously, you want your patients to come to the hospital, leave the hospital in a better way, healthier, stronger, and you don't stay for long. But if your patient have one of these 3 Ds, dementia, depression, or delirium, the length of stay will be longer, the quality of care will be poorer, they will have more falls, and can I surprise you, they will have more infections in the hospital and more mortality because they have one of those 3 things. Right. With my friends in the room from geriatric medicine in general as well, we did a study in Birmingham. This is a study I've done. We looked into people coming to the assessment unit. In England, when patients come to the hospital, they come to assessment unit first, and then we discharge them or we admit them. We looked to the people coming into the acute hospital assessment unit, and we looked for anybody that came with either dementia or depression or delirium. Out of 1,000 patients, we found 10% of all the people coming to the acute assessment unit had any of these diagnoses, any combination of them. And this is unbelievable, this is very low. So we repeated the work prospectively, and I really hope with Dr. Noha leading the old age, and with Dr. Maha and with the people here interested, we can repeat this. Because what we did a prospective study. Every elderly patient coming to the assessment unit, we screened them ourselves for depression or delirium or dementia or combination. And the 10% becomes 70%. What I want you to think about, it's not about giving a diagnosis, but the difference between 70% and 10%, these are real patients who leave the hospital without the care they should have had. And that improves their quality of life. So this is what I want to think about. Why older people come to the hospital then? And I'll give you some surprise. And please interrupt me if it's different from Cairo. So 14% comes after a fall. And I was talking earlier on with Dr. Maha and Dr. Noha about orthogeriatrics. So 14% because of a fall, 12% hip replacement, 9% UTI, water infection, chest infection 7%, stroke 7%. What happens to them? Look what we do to them. People who came from care home, 33% of them came from care home. But the people who went to care home from the hospital to a care home became 42%. So what did we do? Rather than helping them to go back to their homes, we are shipping them to care homes. If people came from their own home, 60% came from own home, only half of them went back to their own home. Why is that? I'm going to blame ourselves. I'm going to say because we did not give them that joint care which looked after their delirium, depression, and dementia. And the care they get on the ward. This slide shows something interesting. If you just look at the first line about the care home, the longer the patient stays in the hospital, the less likely they are going back to their home. The longer they stay in the hospital, the more likely they are going to end up in a care home. Why they end up in a care home? They lose their skills. They lose their support. So do they become better or worse? Worse. Right. Talk about psychiatry in general, rather than old age psychiatry. So people who come to the emergency department for psychiatric manifestations, they usually come for self-harm, they feel despair, they feel all these kind of things. They can't manage their thoughts. And they don't know what to do. But look at this one. Persons with a psychiatric diagnosis, any psychiatric diagnosis, presented to the emergency department 5 times more often than persons without psychiatric diagnosis. Again, with أساتذتنا معانا في الأوضة, I really would like to see that happening here. We do that kind of research. حال الناس في مصر اللي عندهم psychiatric disorders, they come to the emergency with physical complaints more than people without psychiatric disorders. We don't know, but it's interesting. We can look into that. Again, I don't know about Cairo as such, but love to work jointly with you. In the UK, we try really our best, and people get, the budget is huge, and the A&E working all the time, and there are targets, and every patient has to be seen within 4 hours, sorted, everything. But psychiatric patients coming to the ED, the emergency department, for any reason, I'm not talking about psychiatric reason, for any reason, they report that they were treated badly in the ED. Is that similar to what happens in Cairo? Again, this is something we need to know. Right. So if people are treated badly in the ED because they have psychiatric manifestations, why they come to the emergency department? They feel desperate, they feel nobody is listening to them, they feel they are in the abyss, they are in hell, and they want some help. So they accept to come to the ED. Okay. Again, liaison psychiatry with the emergency department. And I just really want to see the same things happening here. When do people come to the ED? More in the weekend or more during the weekdays? In England, they come more in the weekdays rather than the weekends. Maybe because in the weekend they are enjoying themselves, they don't want to come to the hospital. But people who come with the weekend referrals, they are slightly less likely to come to an admission. Again, we can do that work together in the emergency department, see how many people come, when they come, what happens to them, all that work we can do together. Again, I was talking with Dr. Maha, and I was talking with Dr. Maha about joint work. And because of the time, I'm not going to go through this report, but please, just go and see this report on the internet. It's a UK publication. It's called Treat as One. And you will enjoy it. It's about 30 pages. It's fantastic. Good summary. But it says two things. Treat as one means what? Treat physical and mental illness as one thing, but also treat people with psychiatric disorder and physical disorders in the same way. In the same way. Called parity extremes. What is happening to mental health crisis? People coming to the ED in crisis or seeking help at the time of crisis. We put a lot of support to people, and they see the fantastic work around here. Do you think mental health crisis is going up or down? You see the curve? It's been going up. This is real data from Birmingham. It's going up and predicted to even go further up. What's the solution? Dr. Abdurrahman can tell about technology. I'll show you something with the technology. And I'm sure the young people in the room will be better than me, so shout at me if I get things wrong. Right. I'll just show you what we have in Birmingham. We have 5 liaison teams. I'll show you each team what this consists of. Each team costs about £1 million, sterling pounds. And then we have place of safety for people to come. We have a street triage, which I'm not going to talk about today. But again, another idea. In Birmingham, if a patient gets too excited, too unwell in the community, they used to get the police arrested them, put them in the police station for a night or two, and then a psychiatrist goes to see them after a couple of days, and the social worker, and they are in the police station. We never do that anymore. If a patient is unwell in the community, and they call the police goes out with the psychiatric nurse and the paramedic. The paramedic takes care of the physical health, do ECG, look at the wounds. The psychiatric nurse takes care of the psychiatric part, and the police keeps the peace. Also, we have ECT, we have helpline, we go and visit people in their homes, we have a bed management team, we have 50 sites for psychiatry. We have Samaritans, which I think you have here. Is Samaritan here? For people with suicidal thoughts can talk to them online. We have charities, we have social services, we have GPs all the time. Is that good for mental health? In the middle, the patient's absolutely confused, doesn't know what to do, and the crisis is going up all the time. What can we do then? Right. So, Dr. Samir, this is the rate, the rapid assessment and the discharge. We called the trade here recently. Somebody got the trademark for rate and sued us in the court and take the trademark from us. So we lost to that, and that still giving me pain. But what we do, if you want to develop liaison psychiatry, which I'm sure you can do it far better than us, and I'm sure we can work together to develop strong liaison team. Our liaison team work 24 hours, 7 days a week. Doctors on call, nurses, and then if any patient in any department of the hospital have a psychiatric problem, and I mean any department, you just imagine it, any department in the hospital has a psychiatric problem, we'll call the RAID team. And the RAID team will respond to the emergency department within an hour, to assessment unit within 4 hours, to any ward within 24 hours. And then the whole team will be involved with the patient. Medical, psychiatric, social worker, work alongside the other clinicians, who could be surgeons, geriatricians, internal medicine, cardiology, children, whatever, work alongside them. And in Birmingham, just for Dr. Saad, in Birmingham, we see patients from the age of 16 upwards. In Stoke-on-Trent, we see patients from 0 to over 100. So child psychiatry liaison, old age liaison, general liaison, all in one team. So people in the hospital don't need to think, is that child, is that old age, is that general, is that addiction? Whatever the problem is, just send it to us and deal with it. We put training to the staff, our staff and the acute hospital staff, just early intervention. That is the team. So we have two consultants, we have psychologists, we have band 7 nurses, which is like senior nurses, we have band 6 nurses, we have research assistants, we have admin people, and each team is working in the hospital like anything else. Like if you're working in medicine, and then you have a cardiology patient, and non-cardiologists see them, they will come. The reason the psychiatrist will come. This is the referral pathway. As I said, they come, they deal with any referral, sorted it out, discharge them. These are the sort of problems we deal with. So every month in my team alone, we have 5 teams. Every month we see 350 new patients. For you, that's a joke. That's nothing. In the UK, that's a lot. And you see 1/3 of them come for self-harm, 20% depression, alcohol and substance misuse about 13%, psychosis, dementia is about 20%, and anxiety about 6%. This is how we meet the target. We really see the patient NE on average within 20 minutes, though the target is an hour. This is the patient satisfaction. Patients really love it. They think we believe we improved their care, we improved the quality. When we did quantitative analysis, patients were saying how we made the difference for them, listen to them, help to assist with the communication with the medical team. And this is the feedback from the acute hospital staff, the other doctors and other nurses and clinicians. They love the liaison team. They feel them very, very supportive. But England is different. Everything is based on money. You think about patients' quality of care, good, but unless you save money, they will not give you any money. So they gave us £1 million for each team, and I had this assessment by, I've done this paper and I published it. Having the liaison team working alongside the medical teams, if you have a hospital of 500 beds, we save 66 beds every day. By discharging people early, by putting them on the right pathways, treating their depression, treating their cognitive impairment, sorting out their delirium. So that improves the quality of care. When I published that, the London School of Economics did not believe this, and had one of the scary moments of my life when I had a very senior person calling me at home, basically saying, we don't believe you. And we are going to send the London School of Economics to review all the work we have done. And they asked me whether they would like to come clean before we find me. So the London School of Economics came, reviewed everything, and guess what they said? They loved our model. And they said every £1 spent on the liaison team will return £4, which is better than any business you can think of. And from that moment, as Dr. Samir said, the team, the model, just spread across the UK. And I had people from Australia, I had Yale University doing the same thing and applying it. And I'd love to do that here. We had another independent evaluation. Again, they said, hang on a second, you have done this evaluation. We don't trust you 100%. Part of it could be related to what Muhammad Salah was talking about. We'll talk about that later. But anyway, we did another independent evaluation. Used the same methodology again, but completely independent. And what we found, with the liaison team, people who come to the ED frequently, they start coming less. And people who are admitted to the hospital frequently, they get admitted less, and they stay less in the hospital. And when they looked on all the 5 teams, independent from me, they said every pound, if you look at this, every pound is spent on us, we almost return 3 pounds back to the economy. That's very good business. But then they looked into every hospital separately. So the first hospital heft, this is where I work. This is where we have integrated work. Geriatric medicine, with old age psychiatry, with general psychiatry, with addiction psychiatry, all together. Every pound spent will return 5 pounds. But if you look at this hospital, which is a very big hospital called St. Elizabeth Hospital, they did only emergency department, and they did only general psychiatry, just self-harm. Every pound spent, they lost £1.07. So by doing the integrated work in Birmingham, we are actually in one hospital paying for the team in another hospital. Right, enough of rate. So that's his rate, that's the liaison. We did something else. Again, I'm sure أساتذتنا أكيد هيفكروا في الحاجات دي ويشوفوا إذا كان ممكن نعمل حاجة زي كده. عملنا حاجة اسمها Psychiatric Decision Unit, PGU, and I published paper about 6 months ago about it. Our patients come to the emergency department and they feel they are not treated well. The nurses, the doctors are not treating them well. They think they are psych patients, all these kind of things. And when we go to see them in the ED department, the atmosphere is not right. It's quick, accidents, blood, all these kind of things. So we had a little suite, we called it Psychiatric Decision Unit. And we take the patients from the ED to the PGU. How many beds we have in the PGU? Do you want to guess? No beds. It's all recliners, chairs, music, nurses, psychologists, and the maximum stay allowed to the patient in that unit is 24 hours. This is not admission. Just come to our unit and we'll have a better look at you. We'll use the psychiatric interventions. The average length of stay the patient is staying in the PGU is 16 hours. In that time, we'll bring in the family, we'll bring in the social worker, we start looking at the patient, work with them. And what we have done, it reduced the need for psychiatric inpatients by 28%. Because when we see a patient at the ED, and the patient shouting and everything is excited, we say, okay, we'll admit you. But if you have them for 24 hours somewhere else, the whole crisis started going down, and you can have a good look at it. Right. So that's the PGU. I'm going to share something else with you. Especially, you have wonderful 2 big universities, international, in Cairo, you have big population, but also you have Banha, you have Tanta, you have Fayoum, you have Bani Suef, university, you have all these things around you. In Birmingham is in the middle, but then we have around us other cities. Coventry, Birmingham's about, you will laugh at this, Birmingham is the 2nd biggest city in the UK, and the population is 1.2 million, right? So this is like Shobra, it's a different scale. But we have Birmingham, and then we have another big city, about 500,000, called Coventry, and then we have another cities called Sandwell, Dudley, Walsall. These are all cities around us. And guess what? We are not talking together. We are not linked together. Each city has its own psychiatrist, records, inpatient unit, and we are not coordinating our work together, as if we are in separate countries. So we had a very sad case about a girl called Christine Atkins. This girl went to school on the bus. A psychiatric patient got into the bus, for no reasons, stabbed her to death. So obviously he was psychotic. This patient was in Birmingham, but these patients were coming from Wolverhampton. Wolverhampton is another city, knew a bit about him. Birmingham knew a bit, other people knew a bit. Nobody got the whole picture together. So I became responsible of a national program called Vanguard. You know what's the Vanguard? عارفين الحربة السبير بتاع الحربة, that's called Vanguard. In the army, they send the vanguard into the enemy's troop to push into the enemy's troop, and then everybody follows. أنا عارف دكتور منى أحسن مني في اللغة العربية. رأس الحرب. Thank you. Thank you. فالفانجارد يعني رأس الحرب. أنا كنت مسؤول عن لغاية دلوقتي بروجرام اسمه ميريت فانجارد in 5 cities got together, and what we did, we developed a system to link everybody together. الدكتور عبد الرحمن كان بيسألني عن التكنولوجي. First technology we developed a bed management system, electronic, to link all our beds availability across the 5 cities with the same process and the same criteria. So if I don't have a bed, I can't find a bed in the next city. Also developed shared records. That for the first time, we have electronic shared records between 5 cities. And now we have a 6th city wants to join in. And hopefully we can build the fund. But also, and I know, see the people in the room here, we developed a website, interactive website to our psychiatric patients, where the patient in mental health crisis goes in his app, and the app knows where the patient is, and the app can tell the patient where he can get psychiatric help at that point of time of the day, whether it's 2 o'clock in the morning or 2 o'clock in the afternoon. But if the patients want to read about bipolar disorder, they can read that. If the patients want to read about suicidal, what should they do? There's advice there. So that's interactive website. So that's the first technology we did. The other one is, believe it or not, we use artificial intelligence. Anybody interested in artificial intelligence? Why are you interested? What do you do?
I'm reading it.
You're reading about it?
About the technology development of and machine learning.
Machine learning. This is what we're doing. Imagine the flight ticket. What decides the price for the flight ticket? I came on Egypt Air. I'm sure everyone on the flight paid different price. What depends on? Artificial intelligence. So the artificial intelligence put who's going to Egypt at what time, the weather, the school holidays, everything, the demand, what happened in the previous years, and they put the price up and down every day. In Tesco or Sainsbury's or supermarket, when they put goods on the shelf, just do you think we put it like anything? The artificial intelligence tells them on Saturday what people want, on the hot weather what people want, on the cold weather what's going to happen, and they stack it in this way. My question to you, can we predict who of our patients going to fall into mental health crisis? Can we? There's multiple factors. It's not just one factor. Can we do that? Actually, we do that. So we have, I was the lead for another research project called TestBed, and we use artificial intelligence. We have a company, international company, working with us, developing algorithm for us, which we have developed, to predict who of our patients going to relapse. And the idea is, what I don't want to happen, what are we doing now? We wait for the patient to relapse. And when the patient relapses, we try to do something. In my mind, that is what? That's too late. The quality of life, the disturbance in the family, the kids got hurt, all these kind of things. Imagine I can predict the patient going to relapse and I do something before they relapse. Can we do that? Is that science fiction or true? Okay, so this is what we developed. Not me personally, but working with artificial intelligence company who happen to be owning a lot of networks around the world, and they developed for us the algorithm based on our electronic records for the last 5 years. So what they did, we have 5 years of electronic records, which is about, each year we have 20,000 patients, 5 years are 100,000 patients. Each patient has hundreds of entries, so you can imagine the wealth of the data, and they do something very interesting. They split the data into 2 parts, randomly. One part is control, and one part is experiment. They developed the algorithm on one part, and they test it on the other part. Can they predict? So they did that. We did a pre-pilot work, see whether our clinicians will use it, and the clinicians said it's actually very good, and about 57% predictability, and that was just the pre-pilot work. And then we did a pilot after we developed the algorithm with 5 community mental health teams, not related to the research project. Each week, we send them a list of the patients who are predicted to fall into crisis. And we have set all the parameters why we think this patient is going to fall into crisis. And each one has a weight. And then the clinicians will agree or disagree with it and see how that works. And what they found actually it helps them. They give us, this is the clinicians, gives the information in a nice way. They call the patient. Sometimes they decide not to call the patient. They just report back to us the machine got it absolutely wrong. And this is what, again, who would like this most? I was very worried about something else. If I say the big brother attitude, do you know what I mean? Like, حد بيكسس عليك؟ فكنا خايفين العيانين يشوفوا إن إحنا interfering with their data and spoiling their life and testing what is happening to them. Actually, the patient's engagement was fantastic. We had patients in the project who supported it and loved it and said, please, develop something that we can help us to stop relapsing. So this is our vision. Can we develop? Osama.
So George, the predictive, by going through the files, or that sometimes you access the patient directly?
No, you are absolutely spot on, and thank you for this point. It is predicting in our patients, and it goes through their files. This is the stage we are in. What we haven't done is 2 things. This is the future for us. One, we are not predicting the public relapse, but that is the future, using mobile phone network. This is where the whole world is going. I'll tell you something. You and I use iPhone. Your iPhone and the iPhone know about us far more than what we know about ourselves. When we sleep, when we wake up, when we do next, how much you walk. So if somebody was walking every day, 5 miles, and then all of a sudden they are not getting out of the house, maybe they have depression. Somebody does all his text at 9 o'clock in the morning. Now they're surfing the web every night from 1 o'clock in the morning till 5 o'clock in the morning. Maybe they're getting manic. So that is the future, looking into the other bigger data outside the patients. And the other thing is that mobile phone. Can we use the predictive analytics to link the specific patient and have data from the patient? That is the future.
I think it's not a very far future.
No,
it's really
no.
happening. I remember كنا في الميتنج في 2014 في الاولد ايج سايكاتري ميتنج وكانوا بيتكلموا على التكنولوجي ان بريدكت الفولز.
Yes.
Nowadays الابل واتش
can predict your fall.
الفولز وبتبعت دايركتلي للامرجنسي سيرفيسز ان العيان حصل sudden fall that's not very.
Absolutely. I hope before I retire, we'll see that is happening. But what you need to imagine, psychiatry is changing fast, and the other thing, psychiatry is getting out of its shell and working with every specialty, working with technology, working with patients, working with everybody. And this is where we become stronger. Okay, Dr. Rahman, technology thing. This is another technology we developed called CADI. And the CADI is a capacity and demand tool. CADI tells me every second who are the patients need attention for crisis and where the doctors are and how can you link the patient to the doctor. McDonald's, what do you do? How do you order McDonald's now? I don't know. Yes. Yeah, you go to McDonald's, you put it there, they know who's ordered what and what people have doing it. We do the same thing. So that's the CADI. And you can have it in your laptop, in your iPhone. And that gives me some publicity. This is not because I'm that narcissistic, but just to say, prevention, Royal College of Psychiatrists got this up, and they now very keen to work with us on the prevention side. Right? Keep this in your mind, because I show something. Right. Anybody here interested in renal medicine? Renal medicine? Right. I have a study, it's my study. We got £250,000 to do feasibility study, which I called it e-checked. This is the summary. What the e-check does, you know patients on hemodialysis, I'm seeing with Dr. Noha, خدتني مرة فاتت رحنا renal dialysis unit. Very, very good. But patients on renal dialysis, what happens to their cognition? It's worse. Far faster than anything else. We are not sure why. Maybe it's interdialytic hypotension. But what we have proposed is actually to drop the temperature in the machine from 37 to 35 degrees. And I don't want to take all your time, but there's many theories behind that. But the study now is feasibility studies, 2 groups, one on 37 degree, one on 35 degree, and we measure their cognition, depression, frontal lobe functions, and carer's burden. If we show some difference, hopefully we'll be applying for a bigger grant for a proper study. So I'll skip this for your time, but this is how we screen the patients. I was talking to Dr. Abdurrahman, Dr. Samira, you have wonderful opportunity here because you have a big number of patients. I've been working this study for 18 months and managed to recruit 42 patients. I need 90 patients. Here you can recruit them in one day. Right, let me skip this. Respiratory medicine. Anybody interested in respiratory medicine? Don't put your hand up. Anybody has asthma or COPD or has a relative with COPD? I'm sure. Is there any relationship between psychiatry and COPD? Yes. So this is, sorry. Well, it's a chronic disease. Rheumatoid arthritis is a chronic disease. But patients with COPD have more chance than rheumatoid arthritis to develop cognitive impairment much, much younger. So this is a systematic review we published about cognitive impairment in COPD. And this is another study again about COPD. Parkinson's disease. Is Parkinson's disease for neurologists, geriatricians, psychogeriatricians, general psychiatrists? All. So in Parkinson's disease, I have a joint clinic with the neurologists. They look after the Parkinson's disease, I have to say. I don't prescribe L-dopa or anything like that. But guess what I look after? Behavior problems, psychosis, depression, hallucinations, all these kind of things. It's a lot of work. This is a study, case study we published. The patients with Parkinson's disease, and they have, it's almost capgras, but not really capgras. It's not really, we're writing it up as a new phenomenon. I hope I can publish it. I have 3 patients with the same condition. The man comes to me with his wife, say the wife is called Barbara, just making the name up. And he says, I have 2 Barbaras. I said, really? Both of them look the same. Both of them called Barbara. Both of them are wives, but different wives. So it's not exactly capgras when it says, you look like this person. Sorry.
It's wishful thinking.
I was thinking that, yes. actually, this is what I said. This is a very man wishful thinking, very primitive wishes. Absolutely right. So has 2 wives. I have another man who has 3 wives. All of them is called Margaret. And then I don't want to sound silly, but maybe how can I say it? When they are in bed together, he tells her, "Which Margaret are you?" And she says, "I'm Margaret, your wife." He said, "Because if you're not Margaret, my wife would be mad." but I'm a psychiatrist. I don't see this exactly like cut grass. It's slightly different. So we publish this. Okay. Geriatric medicine, towards the end now. Dr. Abdurrahman, technology كمان. I'm developing a study called Memphis, right? And when people in England tell me, "Oh, Memphis, America, Elvis Presley," I say, no. Memphis, ancient Egypt, not Memphis, America. And this is the Memphis study. Older people in any department, not just geriatric department, in any department, with operation, with angina, with heart problems, with bleeding problems, with strokes, and all these kind of things. Our colleagues in medicine in general, happy to deal with everything. Till the patient develops behavior problems. Patients start agitated, hallucinating, shouting, refusing the medication, you are poisoning me, all these kind of things. What's the best treatment for this? Prevention. So what we developed, Memphis is 3 stages. The green phase, where we have all the good geriatric approach to patients. Treating pain, treating constipation, looking at the medication, avoid polypharmacy, all these kind of things. And hopefully that prevent the development of these behavior problems. If it didn't, then we have the amber phase, where we use psychological intervention to calm the patient. Hopefully that will help. If it doesn't help, then we go to the red phase. This is when you use antipsychotics and antidepressants, but also we prescribe to the doctors what to do. But the green phase and the amber phase and the red phase, guess where are they? We can use pencil and paper, but they are all electronic, and the doctors have them. And that's the Royal Psychiatrist again. I don't know whether they say approaching retirement. So I thought the Royal Psychiatrist is giving me a message. Thank you.
دكتور جورج طبعا يعني انا مش عارف اقول ايه امتعتنا. Simplicity about very deep issues in geriatric psychiatry and liaison. What's the energy that you gave us during lecturing? Sharing the audience in the content. الناس كلها انا بص عليها كده 30 minutes. بشكر حضرتك على العرض الجميل ده. تهيألي لو في أي أسئلة لبروفيسور جورج قبل ما الدكتورة نهى. دكتور عبد الرحمن.
يعني هي شدتني بصراحة، أنا هتكلم العربي عشان شدتني اللي هو الارتفيشال انتليجنس مع البريدكشن بتاع الإنجليز. معظم الأمراض بتاعتنا سبجكت. يعني كل أغلب السيمبتومز حتى في البريدكشن احنا بنبريدكت سبجكتيف سيمبتومز. يعني كلها حاجات في الثينكينج، حاجات في الميموري، حاجات في كلها تقريبا. لما العيان يوصل حاجه بيهيفيورال سيمبتومز في الغالب بيبقى ريلابس. فازاي نقدر في الارتفيشال ماشين ديت يعني نبقى فعلا بنديتكت الريلابس قبل ما يريلابس، واذا كان الريلابس هيبقى اصلا سبجكتيف فاحنا هنديتكت ازاي؟
النقطة اللي سيادتك بتذكرها نقطة رائعة. و I really don't think artificial intelligence will replace psychiatry. Just to help us to add another line. Give you another example. I mentioned things about how much we walk, how much we sleep. I have an app on my phone which measures my sleep and gives me a report every morning. How much you have the same? Gives me how much I slept, the quality of my sleep. If the iWatch does the same thing. If my sleep changes, if I every day started waking at 4 o'clock in the morning, after 2 weeks, my machine can tell me what. Do you think you might have depression? Do you want to see somebody? I'll give you another example, which is not my work, but just because I know Noah and Osama are working on the old age side. In Manchester, that's not my work. They're doing predictive analytics on the computer. Your computer. So patients sign on and they just use their own computer. They just put software. And the computer looks at your typing, how much it takes you to reach a website, how much it takes you to open the emails, how many mistakes you do, and your computer measures the changes in your cognitive functions every day over months and months. And the worry is one day I switch on my computer and my computer tells me, go and see Dr. Noah or Dr. Osama for your memory problem. So it can't replace it. There are subjective things, but a lot of potentials which we could use.
بس حضرتك مش ممكن حتى لو احنا قدرنا نعمل بريدكشن مثلا الحاجات اللي الاوبجكت ما ممكن تبقى اوفر تتطبق على السيستم. يعني العيان ممكن العيان احنا عشان هنقول عيان اللبس او كده العيان بيبقى يعني لازم السيمبتوم بيبقى ريزيستد شويه يعني ممكن العيان يبقى فلكتويتنج وما يبقاش اللبس يعني العيان بيجيله فترات يديك فولس بوزيتيف يعني ممكن فولس بوزيتيف تبقى كتيره جدا.
You are absolutely right. عشان كده artificial you are absolutely right 100%. عشان كده artificial intelligence اللي احنا بنuse it we don't call it diagnostic but it is assisting to diagnosis. فالعيان بيجي لي with query mark. لو انا هشخصه مش هشخصه ده يعتمد exactly على الكلينيكال سكيلز والكلينيكال ساينز وكل الكلام ده. But it's not a full machinery process for that specific. That's an excellent point. Just in the same line, I was talking to Dr. Maha earlier on about in the orthopedics عايزين يبعتوا العيان بتاعهم لجيرياتريشنز ويبادوه. And Dr. Maha rightly said, no, keep your patient there. We will come and help you. في انجلترا and I had a lot of pressure on this. الطوارئ الكبيرة عندنا قالوا لنا بصوا كل عيان يجي لنا خليكم انتم مستريحين احنا هنبعت لكم العيان. الانسر بتاعتنا كانت ايه؟ Absolutely not. The patient coming طوارئ should have the physical and mental health together. هقول لك كذا example. في عيانة دي sad story واحد كوليج بتوعنا كنت هانجل بنت patient came للطوارئ دكاترة الميديكس ما شافوهاش خالص. العيانة كمان عندي anxiety when I feel I can't take my breath and I get confused and I have severe headache and tension بس راحوا جايبين السايكايترست قعد معاها قال لها breathing exercise وانكزايتي وروح 3 ساعات بعد كده ماتت. كان عندها برين هامج. ما فيش حد في الطوارئ شافها. فاحنا refused completely موضوع ان بتوع الطوارئ يبعتوا لنا العيان بتاعنا. لازم العيان ياخد full medical examination, blood pressures, ECG, whatever medical problem. يبعتوا لنا واحنا نروح عندكم الطوارئ ونشتغل معاكم ونعلمكم ونقف جنبكم ونخلي بالنا من العيان لغايه ما العيان يمشي معاكم. فاحنا رفضنا خالص موضوع ان العيان يجي لنا احنا نروح. غير كده احنا كان بالمصري هندرس كل المشاكل ديت وما عندناش خبره فيها. عيان جاي لي بشورت بريث وبيقولوا لي بانيك اتاك، وهي مش بانيك اتاك، ده في 1000 ريزون تاني. انا اخد العيان عندي وادي له بول كير ويموت عندي؟ لا، خليك في الطوارئ واحنا هنعالجك. ده بقى الليزن ورك. ومش بس نشوف العيان ونعلم النيرسز ونعلم الدكاتره ونعلم الجينيورز ونخلي السايكاتري يبقى في كل حته. دي الفكره.
التيم اللي شغال يعني معانا
عندنا احنا 24 hours، عندنا nurses trained in psychiatry to go to the first check، عندنا junior doctors، عندنا registrars وعندنا consultants. بس الكونسلتنتس بيشتغلوا من 9 ل 5 وبعد كده في الام كول psychiatrist.
وانا عايز بس انوه قبل ما انسى ان بروفيسور جورج هو المسؤول، هو الكونسلتنت ليزون، هو البيفوت بتاع، هو راس الحربه ما بين جامعه استون وجامعه القاهره. فالناس الجونيور والسينيور اللي عايزين يسافروا انجلترا يبقى في ريسيرش في انجلترا، في براكتس في انجلترا، تسجيل الام ار سي سايك، اي كونسلتيشن. Professor George أعتقد will give help in this.
You will be absolutely welcome through أساتذتنا هنا. I'm really very keen to help to develop the services and the ideas. اللي أنا شفته هنا لما دخلت على النهر الأوضة والجينيور دكتور بتوعها حاجة رائعة. تفكير، potentials, enthusiasm, brightness. Guys, you have fantastic potentials. Very happy to put everything I can to support you, whether in junior level, MRC Psych, PhD, happy to work with you because you have excellent potentials.
وأنا عندي سؤال بروفيسور جورج، بس قبل السؤال الأول عايز أرحب دكتورة سناء أحمد، دكتور سعيد عبد العظيم، مؤسسين الاسم، مع أساتذتنا، مع الدكتور عمر، مع الدكتور يحيى، هم بيشرفونا النهارده. أنا عايز أرحب بالدكتورة ميسي شوقي، أستاذ الصحة النفسية ورئيس قسم الصحة العامة. آسف معلش أنا عشان بريجيدست، رئيس قسم الصحة العامة في القصر العيني. دكتورة هالة فراويلة دفعتي ويعني عشرة قديمة، رئيس قسم الكلينيكال باثولوجي في القصر العيني. حضرتك مدير رعاية المسنين. حضرتك مدير مركز رعاية المسنين وبتشرفينا هنا. فيعني ضيوفنا الكرام بيشرفونا وبيضيفوا يعني بعد كبير لرسالة الاسم. أنا سؤالي لحضرتك بيجي على الإيميلز كتير ليا ولأصدقائي طالبين لوكمز في اليو كي. هل ده له يعني سياسة جديدة في الام اتش او يعني ام اتش اس؟ يعني هل في نقص في عدد الأطباء في انجلترا في الوقت الحالي؟
في نقص كتير قوي سبيشالي في السايكاتريست. يعني انا الديبيوتي ميديكال دايركتور المسؤول عن الورك فورس، فاحنا بندور على دكاتره بشمع ودكاتره يكون عندهم اكسبيرينس. اللوكم لازم لوكم يو نو وات لوكم مينز، يعني بياخد وظيفه لمده شهر شهرين، واللوكم بياخد فلوس اكتر من العادي. يعني الريت بتاعت اللوكم اعلى من السبستانتيف كوست.
يعني ده حصل ليه؟ وهل ده له علاقه بالبريكزيت؟ وهل له علاقه بابتعاد الاطباء في انجلترا، عدم دخول كليات طب، يعني الفاكتورز بيهايند ذس وتاثيره على الام اتش اس؟
So Samir, you're absolutely right, and this is really my area because of the workforce. So كذا فاكتور. أول واحد فيهم الإميجريشن فاكتور. إنجلترا never got it right من ناحية الإميجريشن. فهم يقفلوا الباب قوي ويقفوا ضد الإميجريشن ومحدش عارف يخش ومحدش عارف ياخد فيزا. عدد الدكاترة يقل، عدد النيرسز يقل، عدد الساينتست يقل. فاتحين الباب قوي، الناس تيجي كتير، يقول لا ده كتير فلو تاني. القصة دي بقى لها 50 سنة. فهم قفلوا الباب من 5 6 سنين وناس كتير مشيت وبدأ عدد الدكاترة يقل. دلوقتي حتى الحياة is achievable. لو الناس تعمل بلاب فرصة انك تلاقي شغل كبيرة قوي في السايكاتري. بس في بروجرام تاني I would really, for the junior doctors, I would really want you to think about, and I'd be very happy to support you in Birmingham, called MTI, Medical Training Initiative. We have already got 2-3 people from Cairo with us. So if you are interested, you can do that. You come and work with us for 2 years. They give you full registration, and then you can try to do the MR Society and all these kind of things. Our senior colleagues, they're opening a program for senior consultants. So that was happening. The reasons for that, the immigration. The other reason, number of them, one, a lot of our medical students بعد ما يخلصوا بيسيبوا الطب. حبة medical students احنا عندنا في انجلترا يعني